In this video, I'm going to talk about the clinical features of systemic lupus erythematosus, also known as SLE. So SLE is more commonly seen in females of childbearing age between the ages of 15 to 45, and it's more commonly seen in African American females than in Caucasian females. Now, the exact pathogenesis of SLE is not known, but it's thought to be due to the combination of the environmental, genetics, and hormonal factors. And then studies show that there are autoantibodies that are directed against spliceosomal small nuclear ribonuclear protein, antibodies that are directed against the coagulation factor, antiphospholipid antibodies, formation of immune complexes, as well as the complement activation, all of which cause destruction to the tissues as well as vasculitis. So there are many different tissues that are affected in SLE, and the clinical symptoms present with the exacerbation and remission course. So fatigue, joint pain, as well as malar rash are the most common features of SLE, and malar rash is a butterfly rash over the cheek and bridge of the nose. So just keep that in mind, that malar rash is one of the most common features of the SLE. The other clinical symptoms of SLE include the hilar adenopathy, photosensitivity, Raynaud's phenomenon, where due to the vasospasm of the small vessels, there would be blanching of the distal digits, and so therefore you will have to treat these patients with the calcium channel blockers to prevent the vasospasm of the small vessels. Libman-Sacks endocarditis is another complication of SLE, where there would be sterile vegetations that are present on both sides of the heart valves. And so the way I memorize it is that LSE, or Libman-Sacks endocarditis, is associated with SLE. So LSE is associated with SLE. Next, we have the renal complications, which is the most common cause of death in patients with SLE. And there are two forms of renal complications that may arise in these patients. The first one is diffuse proliferative glomerulonephritis, which is a nephritic syndrome, and so in patients with nephritic syndrome there is less than 3.5 grams of protein secretion per day, while the other form is the membranous glomerulonephritis, which is a nephrotic syndrome, and there is more than 3.5 grams of protein secretion in the urine per day. So with the diffuse proliferative glomerulonephritis, the memory aid that I have for you is diffuse SLE looping or diffuse SLE lupusing. So diffuse goes for diffuse proliferative glomerulonephritis, SLE goes for SLE, and then looping is for the wire looping of the capillaries that is seen on the histology. So here you can see that there are wire looping of the capillaries that are evident on the histology. And then for the membranous glomerulonephritis, the memory aid that I have for you is SLE spank me. So SLE is associated with membranous glomerulonephritis, and there are spikes and domes that are present on the histology. So subepithelial spikes and domes. So here is a close-up image which will show you the subepithelial spikes and domes that are shown in patients with membranous glomerulonephritis. Other complications that can be present in SLE include the cardiac problems like pericarditis, Libman-Sacks endocarditis, which I just discussed with you, and myocarditis. Pulmonary problems like pleuritis, pneumonitis, and pleural effusions. Hematologic problems like hemolytic anemia and leukopenia. CNS problems like seizures, depression, headaches, and cerebrovascular accident. Recurrent abortions due to the presence of the antiphospholipid antibody. So this antiphospholipid antibody causes a hypercoagulation state, as a consequence of which there is problem with the perfusion of placenta, and thus these patients present with recurrent abortions. They present with premature births, preeclampsia, as well as placental insufficiency. And then finally we have the anticoagulant phenomenon, but this is a misnomer because these patients actually have a hypercoagulation state. So due to the presence of antiphospholipid antibodies, these patients have a hypercoagulation state. However, antiphospholipid antibody is associated with elevated PTT, and thus since there is an elevated PTT, the name anticoagulant phenomenon is given to it. But in reality, there is hypercoagulation, which causes recurrent DVTs and pulmonary embolisms in patients with the SLE. In addition, there are antibodies that are directed against other clotting factors, and thus prothrombin time is also elevated in patients with SLE. Now, I would like you to know that patients with deficiency of clotting factors, if you provide them with the normal plasma, that would correct for PTT and PT. In patients with the SLE, however, it's the antibodies that are causing elevated PT and PTT, and thus these lab abnormalities does not correct by giving normal plasma to these patients. So just keep that in mind, that PT and PTT cannot be corrected by giving normal plasma in patients with SLE. I would also like you to note that the antiphospholipid antibody associated with SLE cross-reacts with the cardiolipin, which is an important component of syphilis screening test, which includes the VDRL as well as RPR. And thus patients with the SLE can test positive for VDRL and RPR because the antiphospholipid antibody cross-reacts with the cardiolipin. So in any case, I would like you to know that patients with SLE have a hypercoagulation state despite there is an elevated PTT and PT. And thus due to the hypercoagulation state, you will have to provide them with the long-term anticoagulation with warfarin. For the diagnosis of SLE, you can check for the presence of the anti-nuclear, anti-double-stranded DNA, and anti-Smith antibodies. So the mnemonic that I have for you is called SAND, and stands for anti-Smith, anti-nuclear, and anti-double-stranded DNA antibodies. So the anti-nuclear is the sensitive test. So it's easy to remember that the anti-nuclear is the sensitive test. And since it's a sensitive test, it's the initial screening test that you will have to order. However, this is not very specific, and the anti-nuclear antibody can be present in the other autoimmune disorders, like for instance scleroderma, polymyositis, or Sjogren disease. So therefore, if a patient is positive for anti-nuclear, then you will have to confirm the diagnosis of SLE by checking for the anti-Smith and anti-double-stranded DNA. So anti-Smith and anti-double-stranded DNA, these are the specific lab tests that can be used to confirm the diagnosis of SLE, while anti-nuclear is a sensitive test that is used as an initial screening test. You should also know that patients that are positive for anti-double-stranded DNA antibody have a poor prognosis. Finally, there are medications that can cause drug-induced lupus. And any drug that causes the development of the lupus, in those patients there will be a positive anti-histone antibody. So there is 100% positive rate in patients that have drug-induced lupus for the anti-histone antibodies. And common drugs that can cause development of the lupus include the hydralazine, isoniazid, phenytoin, as well as the procainamide. So the memory aid that I have for you for drug-induced lupus is HIP, and HIP stands for hydralazine, isoniazid, phenytoin, and procainamide. Hydralazine, isoniazid, phenytoin, and procainamide. And then you can remember that HIP, H goes for the anti-histone antibody. So if you give these drugs and the patient starts to develop a malar rash, then the question asks you what type of antibody would be present in these patients. It would be the anti-histone antibody. And then for the treatment of SLE, since these patients are photosensitive, you will have to avoid sun exposure. You have to give them anticoagulation because of the hypercoagulation state. For instance, you can give them warfarin. For these musculoskeletal as well as cutaneous problems, you can give these patients like NSAIDs as well as antimalarial medications like hydroxychloroquine. And then finally, for the more severe cases of SLE, you can provide them with the steroids and cyclophosphamide. And for those patients who have drug-induced SLE, like for instance from these medications, then you will have to discontinue the medication that has caused SLE. And that concludes our discussion.